Thank you so much for inviting me today. Can everyone hear me?
Yes.
Great, thanks. Next slide, please. We're going to talk today about the issues that we address in rehab, but on a very limited basis. First thing is to remind everybody that the medicine of rehab medicine is to look at function in patients. And when we look at what's different, there are some things that are different and a lot that isn't very different. Many patients with leukodystrophies, as all of you all know, have challenges with regards to function and in all areas or domains of function. But some of the things that have become clearer over the last few years is that, and some of them are not very surprising, but one is that there's improved global function when there's improvement in the disease. And that's a lot of what everybody's talking about with regards to treatment, because really the outcome measures look at the health of a child, but many of them primarily look at the way a child functions. So and even with partial treatments, such as the use of baricitinib to treat patients with AGS, leads to significant improved global function and has made much more of a difference than anything any of the rest of us have done. There is also improved tone and function with improved nutrition. And this is something that, although we've known about that for years in other patients, we sometimes forget. And I'm impressed with the number of times that we see patients who really have nutritional deficits to the point of sometimes failure to thrive. And the degree to which those patients have hypertonia and decreased function is pretty impressive. Also, it can be impressive to see the change in both of those things when the body is no longer feeling as though it's being starved. There's clearly, and again, this is not new to rehab medicine, but something that seems to be overlooked a lot of times is that there's clearly improved upper limb function. And therefore, if there's improved upper limb function, improved use of the hand, when there's good trunk support. And for so many of our patients who have increased tone in their limbs, but significant decrease in tone in their trunks, or even for patients who just have decreased tone overall, improved trunk support is really important in order to allow our patients to be able to use their hands better. Two of the things that are out on the market now are not new, but are not at least in my experience, necessarily widely prescribed outside of the leukodystrophy centers of excellence, and sometimes even within that. And those are SPIO suits and DMO suits. And just to be clear, they're not the same. The DMO suit is the ultimate best fabric support system for the trunk and should be considered in every single child, whether or not that's something that ultimately gets used or not. But for children who either don't have access to getting fit for a DMO suit or who are going to be growing too quickly to benefit from it, the SPIO suit is a step down from that. And then other suits, such as the Bennett trunk support or just trunk support in general, is better than nothing, but nowhere near as good as the DMO. So I think that's an important thing for people to remember. The other thing that's coming out of some of the work that's happening now at CHOP with neuropsychometric testing in an accommodated fashion for children who have leukodystrophies is that across the board, cognitive function is higher than we think it is. And parents have been telling us this for years. Those of us who pay attention know that some of our patients, if not most of our patients, are responding to us or to their parents on some level. Sometimes to us, it's to completely ignore us. But cognitive function is average to low average across the board in many, many of our patients for whom it's not really possible for them to demonstrate their level of cognition based on their inability to communicate or to be able to use their limbs to show us what they're thinking. And I think that's really important. And we should look for more information about this going forward. And then finally, good news and bad news. There's new equipment out there all the time that can help with adaptation or accommodation for patients who need it and can help patients function a little bit better. Just a personal caveat recommendation is to look at new equipment with experts that cover sort of all areas, not just through vendors, but through therapists who have expertise in equipment and equipment use, because the last thing anybody wants is a house full of equipment that is not helpful. Next slide, please. So what's new in therapy? Again, not a lot, but some things to highlight. It's becoming clear really throughout the way that pediatric therapy is delivered that episodic or bursts therapy may, and I emphasize the word may, be more effective than continuous therapy at a lower frequency. The studies are not great in order to demonstrate this, but there is a growing body of evidence and certainly growing recommendations from experts, self-proclaimed or otherwise, that episodic or burst therapy may be more effective. Now, what's also pretty clear is that there's not any evidence that there's specialized therapy or a therapy approach that has increased efficacy compared to traditional therapy. The changes that are apparent in therapy approaches that are advertised as specialized has more to do with the intensity of therapy and the way that it's being offered in a burst rather than in the actual therapy that's being delivered. So I encourage people to take a close look at that prior to recommending that patients be involved in specialized therapy, because many of these specialized therapies are very expensive. And for patients who have insurance coverage that will manage that, or who are interested to go, I don't know that any of the therapies are necessarily, I don't know of any that are harmful, but on the other hand, they are very expensive and they frequently require relocation for a patient and family, and that's pretty disruptive. Another thing that is not new, but that is not clearly recognized frequently enough, is that involvement in simply 1 hour of a home exercise program per week is effective in improving function in children with a static problem, such as cerebral palsy. So what that tells us is that the home exercise program is important and that the home exercise program is effective. And I think it's really important as clinicians for us to continue to emphasize that to families, that it's not just what happens with the therapist, but any therapy homework is important and should be carried out. And for when parents have questions about therapy homework or how to get it delivered, it's important to get those clarified. The other thing that's important to remember is that the overall approach to therapy should always be individualized by the therapist who's putting together the plan, but the approaches to therapy remain based on therapy for children with cerebral palsy, because in many occasions and much of the time, that's where we have more evidence based to support therapy approaches. Next slide. So then the other thing that we look at in rehab medicine, certainly in the clinics that I've been involved in, is how to manage tone in order to help children function better. I've already talked a little bit about hypotonia or low tone, which is a really key important part there is positioning and especially trunk support. But when we talk about the management of increased tone, it's important to look at all the ways that can be done. New and improved at least in the literature these days, and also being used. And some of the therapists in the who are here today may want to comment on this, is that vibration therapy has been shown to have a sustained decrease in tone and secondary improvement in function for adults who have increased tone because of strokes. And again, the etiology of increased tone is not necessarily different. The issue is in the brain. So I think that we can be encouraged by the fact that adults with spasticity due to a stroke show improvement with the use of vibration therapy. And therefore, this may be worth investigating a little bit further in our patients. The important part, there are a lot of things that therapists do that decrease tone, such as stretching and prolonged stretching, but none of those things have shown to have much of a sustained effect on tone in terms of improving or decreasing tone. And the vibration therapy is showing that it can decrease tone for at least 6 weeks in patients who use it for 3 to 4 weeks. For medications that are available, there really aren't any new ones. There, in practice, is perhaps increased use of dopaminergic medications and increased use of gabapentin, especially for patients with mixed spasticity and dystonia, and for patients who have irritability that's associated with that. Now, there are new guidelines that have just come out from the American Academy of Cerebral Palsy and Developmental Medicine for the management of or treatment of dystonia with enteral medications. And that's worth reading for people who are treating dystonia in our patients. The other thing, though, that's really important to remember is that the etiology of dystonia or the nature of dystonia may be different in our patients than it is in patients who have a static lesion like cerebral palsy. So important to look at the drugs that are there, the literature and what it can support, and then what the guidelines are from the AACPDM. But a reminder that our patients do not have a static lesion and therefore technically don't have cerebral palsy, although the guidelines may be helpful. It's also turning out that patients with leukodystrophies may be more sensitive to cognitive suppression with medications such as baclofen and gabapentin and the dopaminergic drugs. So I think it's important to perhaps start at a lower dose than what's recommended by weight in patients who have cerebral palsy. And that's important because if patients have significant cognitive suppression, it's very hard to encourage families and patients to try the drugs again if it wiped them out so much the first go round. So I think in looking at that, just an anecdotal recommendation would be to start low, but don't increase the dose slowly. Some of the experts in baclofen metabolism have been talking about that for years now, that most of us increase doses, especially of baclofen, but also of gabapentin and of the dopaminergic drugs too slowly. We don't need to wait as long as we usually do to see whether or not there's an effect or a change. And then the dose can be increased by incrementally small doses, but the frequency of change should be fairly fast, because a lot of our patients also require fairly high doses of the same drugs in order for them to be effective. And as of now, there are no profiles that are published for baclofen metabolism related to patients with leukodystrophies, but again, an opportunity perhaps for research in the future. It's very clear in patients with sort of refractory hypertonia that intrathecal medications are more effective than enteral medications. This is true for everyone who has increased tone, but there are side effects to intrathecal medications that many people know about, and certainly we can talk about more. And new in the last 10 years, certainly, but really probably more in the last 5 years, is that baclofen is now available in 5 milligram tablets. And because the suspension of baclofen is harder to find, not uniformly consistent in terms of its concentration, and not always fully mixed or staying fully mixed, it's much better to try to crush tablets, even if they have to go through a gastrostomy tube or a nasogastric tube, if at all possible, in order to deliver baclofen. It's just more reliable than using a suspension. Next slide, please. The other thing to talk about is, because it always comes up, is that chemodenervation with botulinum toxin is still available and an appropriate consideration, especially for patients who have focal hypertonia. In that realm, Dysport lasts longer than Botox, has not been used as long in this country, but has essentially the same safety profile that Botox does. And both of these drugs are now approved for the management of spasticity in the arms and the legs in children older than, these are FDA approved for children older than the age of 2. Now, that doesn't mean that you can't use these drugs in children younger than 2. Certainly they weren't approved until they weren't both approved until 2020. And we had been using the drugs much longer than that. But the FDA approved dosing profiles are out for both drugs. It's also important to remember that all preparations of botulinum toxin contain some protein, although it's very, very low compared to the original preparations of Botox that came out before 1999. And there's still theoretical precipitation of autoimmune crisis, but that has not been demonstrated in large populations of patients. So again, I think for patients who have autoimmune or immune-mediated diseases, it's important to remember that there is a protein in these preparations, but it is not an absolute contraindication. And then patients with leukodystrophies are at risk for the same side effects as patients without leukodystrophy, but there's no evidence so far in the literature that there's increased sensitivity. This has not been well studied. That's what that was supposed to say, and I apologize for the typo. But again, anecdotally, there's not an increased incidence of patients having greater side effects because they have leukodystrophy than not. And then finally, this has also always been true, but important to remember if it looks as though the injections of toxin are not working, that the localization of injection sites with electrical stimulation or ultrasound improves efficacy for any injection. Intramuscular neurolysis with phenol is also not new, but it does require localization with e-stim or ultrasound. And in our patient population, we've seen fairly good response, especially to the first time with using phenol in the obturator nerve. Next slide, please. And then finally, there are surgical approaches to the management of hypertonia. It's important, I think, whenever we're talking about children with leukodystrophies, to remind everyone that the risk of anesthesia in patients with leukodystrophy may be higher than it is in the general population. And so that's a really important thing to be discussed with whoever might be providing anesthesia, and also important to know that there is an age-appropriate anesthesiologist working with the patient and an anesthesiologist who has some knowledge base related to leukodystrophies. Surgical interventions remain permanent, and I also think that's an important thing to remember, and are not adjustable in patients with degenerative diseases. So whatever is done surgically will be static or permanent based on the time that it's done, and therefore may not be effective long-term the way it's expected to be effective in patients who have static lesions. Some of my patients are teaching me, though, that prolonged respite from hypertonia may be worth the recurrence of tone, as it will happen with selective dorsal rhizotomies or potentially with selective neurectomies. And selective neurectomies, peripheral neurectomies, are becoming more widely used in patients who have increased tone from static lesions. This has been done, again, for years in adults who have increased tone secondary to strokes, and a selective neurectomy can be very useful in terms of changing the tone profile in any limb that is affected by hypertonia, but will not be as likely to be permanent in someone who has a progressive disease or a changing disease. And then surgical intervention is necessary for intrathecal baclofen pump placement. Just to be clear, this is still a mechanism to be able to deliver a medication, and the tone is managed by the medication, which is baclofen that goes into the pump. But surgery is required for the initial placement of the pump. It's required when the battery needs to be changed, because it's better to just put in the batteries last long enough that the recommendations are to put in a whole new pump, because nobody really knows how long the pumps will last. And surgery is necessary in case of complications that involve the function of the pump. And I think that's it. Oh, I'm sorry. And then the other thing that we're paying attention to with regards to rehab is positioning of our patients and what happens to them so that we can position them to function better, but also what's happening to their bodies with regards to positioning. So trunk control, we've already talked about, important for Matt to have seats help with trunk control as well. But just in general, people function better if they have good trunk control. The other thing that's important and that we should be following is hip surveillance, following the CP guidelines, and those are well published and known to everybody. Orthopedic consultation should be important for patients who are demonstrating rapid subluxation or progressing subluxation towards dislocation with the migration index with regards to hip surveillance. That does not necessarily mean that hip surgery will be indicated, but it certainly should be something that is on the table for all of our patients, again, with the same caveat related to anesthesia. And with regards to hip surgery, the pediatric orthopedic surgeons are now renewing the use of guided growth for the management of hips, but that's much more effective and likely to be more effective for patients who have hip dislocation or subluxation secondary to hypotonia rather than hypertonia. And then varus derotational osteotomy, as well as tendon lengthening, is still on the table for all of our patients, the same way it is for patients who have cerebral palsy or other static lesions. And femoral head resection can be effective for patients who really continue to have very significant pain that's related to hip position, whether it's subluxation or dislocation. I think the other thing that's really important to remember is that hip subluxation and dislocation can be very painful. And what the statistics in the literature show is that it's painful in approximately 40% of patients in the population. However, for a given patient, it either hurts or it doesn't. And when something hurts, tone will increase for anybody who has issues with hypertonia. And I was reminded the other day when I saw a patient who had bilateral varus derotational osteotomies, and following the surgery and his recovery from the surgery, which for him was only a few days before he was no longer in pain, his tone went down significantly to the point where his physicians were thinking about decreasing enteral baclofen for him based on how well he was doing. And finally, with regards to positioning, all of our patients are at risk for scoliosis. Whether or not repair happens it should be based on the severity of the curve and the rate of progression and what the repair would mean for quality of life as well as function for the individual patient who's involved. And I believe that's the end. Thank you very much.